Hello, everybody. Welcome to this HCP Live special report. My name is Dr. Hersh Shroff. I'm a transplant hepatologist with the University of North Carolina. And for today's discussion, which is aptly timed for the close of Alcohol Awareness Month, we're going to talk about the importance of addressing the stigmatization of alcohol use disorder with the aim of improving outcomes for alcohol-associated liver disease. I'm really fortunate today to be joined by two fellow experts in these fields in the form of Dr. Chris Kahler and Dr. Jay Luther. Thank you both for joining me in today's discussion. Why don't you each introduce yourself briefly to our audience, and then we can dive right in. Dr. Luther, we can start with you.
Yeah, thanks, Hersh. I'm Dr. Luther. I'm a hepatologist at Mass General Hospital, where I lead our alcohol liver center, specializing in the care and the research of patients with alcohol liver disease.
Great, thank you. Dr. Kahler?
Hi, I'm Chris Kahler. I'm the director of the Center for Alcohol and Addiction Studies at the Brown University School of Public Health and a professor of behavioral and social sciences and a clinical psychologist whose work focuses on interventions to reduce alcohol use in a variety of settings.
Thanks, that's awesome. As mentioned, today's discussion is centered around addressing the stigmatization of alcohol use disorders. So to start the conversation, I'm going to start with a two-part question for Dr. Kahler. Dr. Kahler, first, can you provide us with a brief overview of the different forms and definitions of stigma itself? And then after that, could you just describe how public stigma around alcohol use disorder may contribute to delays in seeking care for liver disease?
Yes, absolutely. So stigma is a pretty complex construct. It's really a social process where devalued identities or behaviors are systematically excluded, discriminated against, stereotyped within a cultural or societal framework. So that's the process of kind of what stigma is at a broad level. And it manifests at both social structural levels and individual levels. So on the structural or social level, it has to do with cultural norms, policies, practices, our language and our dialogue kind of as a culture about given behaviors or given social identities. On the individual level, there's the perceiver who might assume that someone, for example, with an alcohol use disorder has certain characteristics or perhaps certain moral failings that have led to them having an alcohol use disorder. So that would be an example of a perceiver having stigmatized an identity of someone with an alcohol use disorder. On the individual level, someone with an alcohol use disorder or with any stigmatized identity might experience stigma in terms of having people actually discriminate against them or behave differently towards them because of their identity. They also may anticipate stigma so that they go into certain encounters, social encounters, expecting that people react to them differently because of their identities. And of course, everyone carries multiple identities. You could, for example, race, ethnicity, religion, body size and shape, all of these identities, both of which are visible and invisible, intersect and can lead to specific forms of stigma for individuals. Anticipated stigma can also, and experienced stigma and kind of broader social stigma can also lead to internalized stigma, where people begin to think about themselves differently because of a certain identity that they have. So, for example, someone with an alcohol use disorder might be experiencing shame and blaming themselves because they've internalized the kind of cultural norms and discussion around alcohol use disorder. So the consequences of that, to the second part of your question, are that people in general want to underreport their drinking. And it's kind of common in society to say, well, I drink, but I'm not an alcoholic, right? People don't want to have a stigmatized identity. Therefore, they may underreport their drinking in their primary care settings. And if their drinking is above a certain level, it also may be the case that the clinician is hesitant to raise it because they're worried about having a discussion about a stigmatized topic. And then if people find that they're having signs or they're being referred to a liver specialist, they may worry that going to a liver specialist for a disease that could be caused by their alcohol consumption, again, gives them that stigmatized label and may make them very hesitant to seek care. So it operates in kind of all of those levels. And then, of course, once people are seeking care, it's possible that they may experience stigma in those contexts as well.
Yeah, as you talked, I really it resonated with me because as I've done this more and more, that self-stigma, that internalization that people start to kind of feel, really, it becomes very visible and evident in this patient population. I think something that hopefully we can continue to address. I'll turn to you now, Dr. Luther. Can you address structural stigma and, in particular, the role it plays within healthcare systems in perpetuating disparities for patients with alcohol-related liver disease? And sort of what systemic changes and what have you been doing to help mitigate these disparities?
Yeah, I think that's a great question, and I agree with everything Chris said. That unfortunately, stigma is so important in determining the outcome of care for these patients, both at the structural level and at the individual level. And unfortunately, as you mentioned, I do think there are certain aspects within the healthcare system, unfortunately, that have perpetuated these stigma, that have made it harder for patients to come in and get care that they need, not only for their alcohol use, but for their liver disease. Some of those are very granular and specific. For example, one of the big things that makes a difference to patients and that we have done a very poor job of, certainly in the hepatology world, but also in the medicine world as a whole, is even just labeling patients with the disease. So traditionally, we had labeled patients with alcoholic liver disease or alcoholic hepatitis. And that term alcoholic certainly carries a stigma with it. And unfortunately, when patients hear that, certainly they feel like they are being judged. And that's why they have the disease. And I think what we've tried to do as a group, as a whole, is to be more cognizant of that. And because of that, have actually renamed or changed the ways we address alcohol-associated liver disease, alcohol-associated hepatitis, and gotten rid of the term alcoholic. So there's some very specific things that I'm not even sure we realize were contributing to stigma within patients. And then there's some structural things that you mentioned and Chris I had kind of hinted on as well. I think a big one for us in the hepatology world was that the way the system was set up previously, the care for the patient with alcohol use disorder was very separate, meaning they would get their alcohol-related care with an alcohol specialist or with an addiction specialist and get their liver-related care with hepatology. And there wouldn't be much overlap there. So they would come and see the hepatologist, and the hepatologist would address all the liver-related issues that they're dealing with and tell them, look, you have to stop drinking. You need to follow up with your alcohol addiction specialist. And I think for patients, what it did for them is it made them feel like we were blaming the alcohol use, that was the sole reason that they had developed liver disease. When in fact, we know very well that while alcohol certainly contributes to liver injury and to the development of liver disease, there's so many other causes that can accentuate that: genetics, obesity, etc. So one of the big things we've done here is to reinforce to patients that while alcohol use and excessive alcohol use certainly contributes to the disease, that's one component of their care. It's not everything. And so we want to help them with all aspects of their care. The other thing is incorporating a team approach. So what we do here now at MGH is we see the patients as a team, a hepatologist, an addiction specialist, a social worker, so that we can present to the patient that we are actually one team with one goal in mind, and that's to get you feeling better, to get you healthier. And there's many components to that, and we're going to address each component with you equally. And I think we hope and we think that reduces some of the structural stigma that had been in play traditionally for the care of these patients.
I love that. Integrating multiple individuals, making things more comprehensive. Thank you. So for the next question, I think either one of you can answer this. I'll stick with you, Dr. Luther, but Dr. Kahler, please feel free to chime in. So how you kind of started to allude to this, Dr. Luther, but how can mental health substance use specialists collaborate with hepatologists and vice versa to develop these comprehensive treatment plans to address both the psychiatric and the medical consequences of the alcohol use disorder and the alcohol-related liver disease? Maybe some sort of examples of how you're doing it or kind of other things you've seen elsewhere.
Yeah, I think this is absolutely critical to determining how we end up dealing with alcohol-associated liver disease and alcohol-related organ injury in general moving forward, that there has to be integration of care for these patients. I am fortunate here in Boston that we do have a wealth of addiction focused health professionals that allows us to collaborate with them very closely for the care of these patients. And we kind of taken a two-pronged approach. We care for patients who actually are at risk for developing liver disease because of their alcohol use. And we also take care of patients who already have established alcohol-associated liver disease. And we do that in a multidisciplinary approach, meaning, again, we see the patients in conjunction in the same visit with the addiction health professional. And we do that both in the inpatient and the outpatient setting. I do think that there has to be investment from the healthcare system to support these type of endeavors, to support multidisciplinary care at one time. But again, I think the long-term outcomes justify it.
Dr. Kahler, anything to add there?
Yeah, well, certainly what's being described there is really a state-of-the-art approach, right? Where you doing everything in an integrated way makes it clear that a person is a whole person. And I think one of the other parts that you mentioned in there, Jay, was social work as well, right? That alcohol problems don't exist independently, are not just the individual. It has to do with an individual's own experiences and makeup, but also the social conditions in which they live. And to expect that the individual necessarily will have full control over their capacity to say, I can stop drinking tomorrow, is not realistic for many people. And it involves not just the involvement of psychiatrists, but social workers or psychologists, other people who can think about the social determinants of health, because those are often driving factors both in alcohol use, but also in delays in seeking care, for example. People with less resources who have been more marginalized for a variety of reasons, including their socioeconomic status, where they live. All those factors contribute both to the alcohol use and to their interactions with the medical system. And so I think having those and addressing those together is really a fantastic approach. One other thing that's been addressed, I think the field of HIV has particularly been leading in this, is the value of peer support as well. And so I think that's something we can think about in kind of all fields of medicine, is having peer navigators who can share experiences around recovery. For example, recovery coaches or recovery peers or specialists are another resource that's kind of growing nationally, and maybe another way to integrate another supportive person that can also reduce stigma by seeing that there's other people who've had these similar experiences that they.
Yeah, I would just add, I mean, that to echo what was already said is, the visual of when you come into the room to see an individual or a patient with another provider alongside of you, and you show that sort of united face, I think really does indicate to that individual the seriousness of the way we kind of consider both of these conditions together, right? The alcohol use disorder and the liver disease, and perhaps if there's a psychiatrist involved, the underlying mental health disease, and that kind of forward face that we put forth, I think really does impact how patients start to understand their process and how we're going to help them with it. So I think we'll end with a question. Again, either of you are welcome to answer this. Maybe Dr. Kahler, we'll start with you here. But what would you say are the most pressing research priorities or policy changes that our community needs to pursue to kind of better understand how to address stigma in the context of alcohol use disorder and liver disease? And are there collaborations amongst all these disciplines that we've already mentioned that can really help drive these research priorities and policy changes?
Yeah, I think I'll talk a little bit more broadly than the context of liver disease care, because that's not kind of where I'm located. But I think kind of upstream a little bit from that, and Jay referred to this, is people at risk for developing liver disease who may have initial signs, that our capacity to screen for unhealthy alcohol use, and that's often a really helpful word for us to use, is unhealthy alcohol use. It makes it easier for a physician to say, in primary care, that your alcohol use may not be healthy. and here's why. And I would like to do some investigation to see whether it's having some negative impacts, as opposed to, I think you need to quit drinking and I'm going to refer you to a liver specialist, right? To kind of begin those conversations so we can get people earlier in potential progression and identification of liver disease. I think that's a really, really high priority. And it also might mean that kind of the tools to screen for liver disease in kind of early stages need to be more accessible, more common, because we think about cancers, for example, screening that we can do earlier to identify kind of initial markers are going to lead to much better outcomes.
Dr. Luther, anything to add there?
No, I absolutely agree with Chris. I think one of the unfortunate issues we have in the hepatology world is we don't have great therapies once alcohol-associated liver disease becomes advanced. And so to kind of amplify Chris's point, catching patients early, plugging patients in who are at high risk for developing disease so they never develop disease. These are critical pieces to the puzzle that I do think need more attention.
Well, thank you both for this enlightening conversation. The two of you are definitely thought leaders in this area. I know I've benefited from this conversation. I'm sure our audience members will really appreciate the insights that were shared here today. Before concluding, I just wanted to say thank you again to both of our guests, Dr. Luther, Dr. Kahler, for joining, and thank you to our audience for listening to this discussion. Bye-bye, y'all.
All right. Thank you. Bye.